Our last endemic fungal infection we'll talk about is histoplasmosis. There are a couple of different varieties. There's a species called Histoplasma capsulatum. There's a variety that we see in the US called variety capsulatum. There's Dubosii in other parts of the world. So we're going to focus mainly on capsulatum, which can cause pulmonary and disseminated disease in parts of the US and in Latin America. As you see, here's kind of the range of histoplasma. It overlaps significantly with the range of blastomyces, but we tend to not see it on the West Coast. So kind of these folks down here in Texas, they get everything. Sorry, Texas. But, so on the West Coast, we get coccidioides, Midwest and East Coast, histoplasmosis, and blastomyces. In vivo, so in the body, the yeast form is actually intracellular, and that's pretty unique. We don't often see eukaryotic pathogens go intracellular all that much. I mean, they can, obviously, but we tend to think of them more as extracellular, but you can see they are small, so they can go intracellular. Histoplasmosis tends to be associated with exposure to bird and bat droppings. So remember, histoplasmosis and blastomyces have overlapping geographic ranges. We tend to see blastomyces associated with decaying organic matter, leaf litter, dead trees, like all that kind of stuff. Histoplasmosis we tend to see with bird poop and bat poop. So in caves, decaying buildings, pigeon roosts, right? So that's the difference, right? So if you happen to be practicing medicine or on the East Coast, or maybe you've got a patient who recently returned from the East Coast and they're developing symptoms that make you think, endemic fungal infection, ask them what they did. If they went spelunking in Missouri, you're like, probably histoplasmosis. If they went hiking on the Appalachian Trail, maybe blastomyces, right? So you can think about those types of things as you are talking to your patient. But as with all of our systemic or endemic fungi, inhaled, right? Spores, conidia, whatever you want to call the structure, it's the inhaled form. It gets aerosolized, especially when the droppings dry out, and it then reproduces in the lungs. So the structure that you inhale will germinate into a yeast in the lungs, and actually being phagocytized is what promotes that formation of the yeast. In patients who have a low exposure, right, they didn't inhale that many of the conidia structure, asymptomatic. Patients who inhaled a lot, you're in a really gross bat cave, or, you hung out under a pigeon roost for some whatever reason, that high inoculum can lead to symptoms. And we tend to see that as more of a self-limited pulmonary infection. And it's actually estimated that anywhere from 60 to 90% of people in the Ohio and Mississippi River valleys have been exposed to this infection. It's super common. Bats and birds are really common in the US. So encountering their feces, their droppings, right, is not outside the realm of possibility. Rarely, patients can experience secondary symptoms that are really highly inflammatory. And so you can have a type of fibrosis response where you have constriction of the heart and large vessels. So that's something that you as the clinician might want to look out for. And again, super rare, 1 in 100,000 patients will develop progressive pulmonary disease. So I guess we look at it as the cost benefit, right? People on the East Coast, there's a couple of different fungi they can be exposed to, but those 2 fungi are less virulent than the one on the West Coast. 1 in 2,000 patients will develop a disseminated disease, and it often will go to the mouth. So you'll have oral ulcers, but you can have patients who experience weight loss, fatigue, an enlarged liver or spleen. Patients who develop what's called a subacute infection, they have similar symptoms to patients who've developed the chronic infection, but the fungus will go to the bone marrow, the adrenal system, the heart, the central nervous system, and this often results in death. And then, of course, acute, which is very rare and is almost always seen in people who are severely immunocompromised or children under the age of 1. Those patients will experience septic shock-like symptoms. So think about when we talked about bacteria, when we talked about cytokine storms, how that leads to shock in the body. So similar symptoms to that. And this, as you might imagine, can be fatal relatively quickly. What we tend to see is that it can be tricky to diagnose histoplasmosis, especially through, all of the types of techniques, basically. It depends on the disease manifestation, which type of test is going to be the best. So for disseminated disease, an antigen test is best. For a self-limited infection, culture is not very good at all. Histopathology isn't great at all for diagnosing histoplasmosis. And serology isn't great for disseminated disease, but works pretty well for chronic pulmonary or self-limited infections. So when you're trying to diagnose histoplasmosis, you might want to try a multifaceted approach. Severe infection, as you might imagine, treated by amphotericin B, followed by one of the azoles. Chronic pulmonary, also amphotericin B, followed by an azole for 1 to 2 years. AIDS patients may require lifelong therapy with an azole. So again, it's important to take a really detailed full medical history. And unfortunately, our poor HIV patients are already taking lifelong antiretroviral therapy. Then they get a fungal infection. Now they're on lifelong antifungal therapy. They end up taking so many pills every day just to keep themselves healthy. But it's really, really critical that they do so.